She is a gynecologist and endoscopist in HRH Princess Maha Chakri Sirin Hong Medical Center in Nakhon Nayok, Thailand. She is currently assistant professor of that medical center and once fellow in APAGE. And her topic today is laparoscopic versus open radical hysterectomy in women with early stage cervical cancer. And welcome, Professor Tanitra. Time is yours.
Okay, thank you for your kind introductions. Can I start now? Can everyone hear me? Hello?
Yes, we are here.
You are on the air. Go ahead.
Okay. Thank you for your introductions and thank you for having me today at this conference. Few years ago, I just completed my fellowship training from APAGE, and at that time, there was a hot issue about an unexpected result from lab trials. So when I came back to my country, I and my most respected teachers, Professor Lee and Dr. Huang, we started to do a review about the long-term surgical outcomes of women who undergoing laparoscopic radical hysterectomy. The findings are pretty interesting and I would like to share to you all. Everyone knows that early stage cervical cancer, the mainstay of treatment is radical hysterectomy. Even minimal invasive surgeries can provide the benefit in terms of, sorry. Hello? Hello?
We are here.
Any problem now?
We can hear you, but the slide is not presented in the screen now.
Sorry.
Tanitra is too close to your monitor. So
I opened my PowerPoint already, but can you see my slide?
Hi, Cherry. Can you face the light, face your window? Because your face is dark. Can you open your light shadow? Okay. Okay. And can you share your slides?
Okay. Okay. Can I start now?
Yes.
Okay.
Share your slides.
Okay. Should I continue the presentations?
Yes.
Okay. Even the minimal invasive surgery provides a benefit in reducing short-term surgical outcome, ensuring that long-term surgical outcomes are not compromised is vital. Most of reviews compare the perioperative morbidities, and our studies find that minimal invasive surgeries reduce short-term perioperative outcomes. We would like to do the review the systematic reviews about the laparoscopic versus open radical hysterectomy in order to complete and updated data in women with early stage cervical cancer. Here is the study design. The populations, a group of women who underwent abdominal or laparoscopic radical hysterectomy with or without pelvic lymphadenectomy. A search from PubMed, Medline, and SciDirectors were conducted. We limit only comparable studies since 2000 to 2018 and only in English language. The primary outcomes focus on survival outcomes.
Excuse me, Cherry. We still didn't see your slide. So we need you to operate on your computer, share the PowerPoint.
Sorry, I don't know how to share my PowerPoint.
Cherry, please press the button from the left. The number 3. There will be the sign to the up.
Okay, sorry.
Yes, correct now. And you can continue your presentation now.
Okay, sorry for my mistake. Okay. The populations is a group of women with early stage cervical cancer who underwent abdominal or laparoscopic radical hysterectomy with or without pelvic lymphadenectomy. A search from PubMed, Medline, and CyDirect were conducted from 2000 to 2018, only comparable study and in English language. The primary outcome focused on the survival outcome, including 5-year disease-free survival, 5-year overall survival, the recurrent rate, and disease-related death. The secondary outcomes focus on the operative outcomes and pathological outcomes, including adjuvant treatment, deep stromal invasion, lymphovascular spread involvement, parameter involvement, the tumor size, positive margin, lymph node metastasis, hospital stay, bladder dysfunction, perioperative complications, blood transfusions, estimated blood loss, operative times, and the number of pelvic lymph node retrieved. The publication by us was controlled by performing a funnel plot analysis. After we accrued an early event and non-comparative study, 30 studies were included. 7 were prospective and 23 were retrospective studies. Almost 790 women derived from prospective study and more than 5,000 from retrospective studies. The conversion rates range from 0 to 16%, but only 1.6 to 2.2% from prospective studies. The mean age and BMI were comparable between two approaches. 7 studies reported that the surgeries were performed by an experienced laparoscopic and oncologic surgeons, and 1 study performed by fellows or residents of gynecologic oncology under supervision of skilled attendants. In this study, the conversion rate was 10%. The question 1 was, does the laparoscopic radical hysterectomy in women diagnosed with early stage cervical cancer increase survival rate, death rate, or decrease survival? Here's the results of 5-year overall survivals, including patients, more than 1,200 patients. The survival outcome in terms of 5-year overall survival were comparable between laparoscopic and abdominal radical hysterectomy without significant. And also the result of 5-year disease-free survival from more than 1,000 patients. The results were comparable between 2 approaches. And the both sides are perpendicular lines were symmetrical. That means the publication by us of this study was not obvious. Here's the results of recurrent rate and death rate, which were comparable between laparoscopic and abdominal radical hysterectomy with low heterogeneity. The second question focuses on the negative cancer factors which drive adjuvant therapy. This table shows the percentage of patients with margin positive, high, large tumor size, parameter positive. All of this parameter shows no significant difference between 2 approaches. In terms of the mean number of lymph node metastases, 1 study of Solomon reported higher number of patients with lymph node metastasis was higher in abdominal radical hysterectomy significantly. This study had higher conversion rate than others, 16% in laparoscopic group. In terms of deep stromal invasions, most of studies except 2 report no significant difference between 2 approaches. 1 study from Park reports higher in laparoscopic group, and 1 study from Top Test reports higher in the abdominal group. But both of 2 studies reported no significant difference in terms of overall survival and recurrent rate. The third question, what are the benefits of laparoscopic radical hysterectomy over abdominal radical hysterectomy? The number of pelvic lymph node retrieved showed no significant difference from 14 studies. 9 studies report higher in abdominal group and 2 report higher in laparoscopic group. However, no difference in metastasis node between two approaches in all studies. In terms of operative time, the results vary widely, but since 2016, the operative time in laparoscopic group reported to less than 300 minutes. The increasing of surgical skill could be explained this. Almost all studies except one report significantly shorter hospital stay in laparoscopic groups. Another ones also report shorter but not significant difference. Laparoscopic radical hysterectomies also provide the benefits in terms of lower blood loss and lower percentage of blood transfusion. The rate of intraoperative complications was similar between two groups. Most of studies reported laparoscopic had lower postoperative complication rate, but not significant difference. 19 studies from 15 studies report no significant difference in bladder dysfunction. What about the result of Asian versus non-Asian countries? There were 11 studies from Asian and 19 from non-Asian studies. The several outcomes were comparable between Asian and non-Asian countries. Same as the operative outcomes, the results were comparable. But there are some points in pathological outcome. In the red box, you can see here is the results in laparoscopic groups. It seems that the patient with negative cancer factors such as lymph node metastasis, premature involvement, deep stromal invasions, it seems higher in Asian study. It could be explained by the difference in technical skill or natural history of disease. The net results of our studies are no significant difference in 5-year disease-free survival, 5-year overall survival, recurrent rate, and death rate between two approaches. Laparoscopic radical hysterectomy also provides the benefits in terms of lower blood loss, blood transfusion, lower post-operative complication, shorter hospital stay with similar intraoperative complications. The result of operative time and the number of lymph node retrieved vary widely. The learning curve and experience of surgeons could be important factors. In comparison with other studies, here is the other reviews reported in 2015. This study conducted from the database from PubMed, Medline, Embase, and Clinical Library and Biosys database. This includes Early 12's original study. The results show no difference in terms of overall study from 3 studies, in terms of overall survival from 3 studies and 5-year disease-free survival from 5 studies. And here is another reviews. This study include the paper from Chinese National Knowledge Infrastructure through the 2nd February 2016. Include 23 studies and more than 4,000 patients. The results show the recurrence was recognized in the laparoscopic group, but the difference was not significant. In comparison with other studies, our reviews include a greater number of studies for the survival outcomes and more updated data, and also support the previous finding. However, there are some limitations of the first, we do not include non-English literature and unpublished data. That could be result in publication bias. And no randomized control trials was analyzed in this study. We didn't subdivide the type of radical hysterectomy in type 2, 3C1, or TC2 in this analysis. And some of studies reviewed laparoscopic and abdominal radical hysterectomy during the same period, whereas some review from the different periods of time. This could be result in time bias. In conclusion, our review suggests that the laparoscopic radical hysterectomy could be performed safe and effectively. It provides more advantage in terms of reduced blood loss, lower blood transfusions, less hospital stay, and less perioperative complications. However, training and certifications is very important. And here is the famous trial, the first randomized control trial from MD Anderson Cancer Center. The results of this study shows survival outcomes in the minimal invasive surgery. This gives a lot of unanswered questions. And this slide shows the participating country from lifetime. This includes in Brazil, Australia, China, Peru, and United States. Compared with our review, it's quite different. Most of studies conducted in Korea and United States. Also, we have 2 studies from Taiwan. There are some limitations of lifetime. First, the criteria of trained surgeons only submitted 10 outcome data and 2 unedited video were not enough. And this time was terminated so early. This time did not mention about the detail of laparoscopic techniques, which may differ in each institute and result in poor outcome. The available recurrent rate and high survival rate in abdominal groups compared with previous literatures. And there is no central pathological reviews. The data of tumor grading and tumor invasions was missing in 1/3 of patients. And this study was underpowered to evaluate outcome of tumor less than 2 centimeters. After lifetimes, another trial was published. This trial using the National Cancer Database and SEER database from United States. Each arm consists of patients, more than 1,000 patients. And this study supported the results of lifetime that the patient who underwent minimal invasive surgery had shorter overall survival outcomes significantly. But in subgroup analysis, it's revealed that minimal invasive surgery in laparoscopic group and small size of tumors were not associated with higher risk of death. And here is another paper from Koreans. This study used the Korean Health Insurance Review and Assessment Service database. Each arm consists of patients, more than 3,000 patients, but no robotic operation in this study. The result revealed the patient in laparoscopic groups was associated with better overall survival with a hazard ratio 0.52. While the result of Korean studies opposite to the results of the LAC trial and the study from US. This slide, I would like to compare between the time periods and the numbers of patients recruited in each study. If you can see in Korean country, only 4 years, they can recruit the patient more than 6,000 patients. But in study from multi-center and US database, it's much less than study in Korea. The slow recruitment might be due to the rarity of tumor in Western countries, and the result between Eastern and Western countries may differ. So we need further study to explain this conflicting finding. So we have to wait and see for this study. This is an ongoing study. Professor Lee just gave talks already. It's the minimal invasive therapy versus open radical hysterectomy. In the last slide, I would like to summarize that the laparoscopic radical hysterectomy could be performed safely and effectively in selected patients. You can use preoperative MRI to assess the proper patients to do this kind of surgery. Surgical and technical skills are very essential. Lastly, and most importantly, the patient should be informed about the risk and benefit of each procedure until more data become available. Thank you very much.
It's a wonderful presentation. Is there any question from the audience or website? I think it's quite clear, and the metal is very important. Okay, if not any question, well, I see maybe